My name is Michael Osborne. My background is in genetic counseling, so I do have several years in clinical practice as a genetic counselor. I'm located in Raleigh, North Carolina, so that clinical experience was at UNC Chapel Hill. But for the last 5 or 6 years, I've worked as a medical science liaison for diagnostic laboratories. So I do work for Menarini. Again, very quickly, just who is Menarini? And I only showed this because Menarini is relatively new to this space, but the technology is not. So I'm only going to allude to the technology one time, or excuse me, the brand name of the technology one time on this slide. So again, the name of the test for circulating tumor cells is Cell Search. And Menarini, the reason that there might not be the brand recognition, if you will, is that it wasn't until very recently when Menarini actually purchased the cell search technology from Janssen and then started offering the testing in 2022 after that transition was complete. But as you can see, we did the cell search technology did receive FDA clearance for in 2004, so a little over 20 years ago. So what is meant by the liquid biopsy? Let's start breaking down some of these science terms. And again, in particular, I'm going to be focusing on circulating tumor cells, or CTCs. So a liquid biopsy, as a high level, means that it is a way to interrogate or look at a patient's cancer through a blood draw, hence the liquid part, peripheral blood being the liquid. So there are many different ways to do liquid biopsy testing, but high level, if we look at this illustration here, pretend that this is a cancer, a tumor cell, or a cluster of cells. In this example, it could be breast cancer. And information or contents from that primary tumor do end up in the bloodstream. Again, that is what allows us, that biological phenomenon is what allows for the development of liquid biopsy products. But high level, a tumor will actually release those contents into the blood in two different ways. And one is through something called circulating tumor cells, where entire intact cells actually slough off of the primary tumor and end up in the bloodstream. So you can see that, again, they are intact. These red dots are the nucleus where the DNA is contained. And so that is, again, what is meant by a circulating tumor cell. And that's what I'll be focusing on primarily for our talk today, is technology that will allow for the detection and investigation of those circulating tumor cells. But liquid biopsy can also refer to what's called cell-free DNA or cell-free RNA. And so this is a process where instead of the tumor sloughing off an intact cell, the body actually will, attack, for lack of a better word, that primary tumor. And it'll undergo a necrotic process, meaning that the cell itself dies. And when that happens, the dead cancer cell releases its contents into the bloodstream, which includes the genetic components. So when a cell undergoes that necrotic process, releasing its genetic information directly into the bloodstream, it's called cell-free DNA or cell-free RNA. And most of the tests that are on the market right now, whether in clinical trials or commercially available, are leveraging cell-free DNA, cell-free RNA, which again is the fragmented components that are outside of the cell. Both of these are valuable tests that can provide some overlapping information, some different information, and I believe some of our other panelists are going to talk about the cell-free DNA RNA component in more detail. So as a final reminder for my talk today, I'm going to be talking about circulating tumor cells specifically. High level, the way that the technology works, it is validated and FDA cleared for metastatic breast cancer, but it is also available for use in many other cancer types, and essentially any cancer that is considered a carcinoma, which in adults accounts for 80 to 90% of all cancers. Um, so a carcinoma just means that a cancer is derived from what's called epithelial cells. And so the way that the technology works is that there's actually almost a magnetic capture that targets a particular marker on the cell surface that indicates that a cell is again is epithelial derived. So again, indicating that it could be a carcinoma. Once the magnetic field has been applied, pulling out all of those all of those cells that are identified as epithelial in origin, then there's several different stains that are applied that provide further clarification on whether or not we're looking at a tumor cell. Most importantly, we apply different stains for what's known as cytokeratin, which is plays a structural role in the cell. But we know that in cancer cells, it is overexpressed. Certain combinations are overexpressed. So this is how we're able to capture tumor cells and then identify that they actually, how we're able to capture epithelial cells and then identify that they are actually from a tumor. Once we have completed this technology, where the laboratory is actually able to further characterize these and even quantify or enumerate them, meaning that we're able to count how many of these circulating tumor cells are present in patients' blood. So a couple of reasons why that is important, that ability to enumerate and count, track over time, is that we do know that throughout a patient's cancer journey, they'll be initiating different treatments, they'll most likely have a response, and then inevitably there'll be relapse followed by another treatment. And so by performing circulating tumor cell testing serially, every few months or as would be recommended based on your individual patient provider conversation, we're able to track the number of those CTCs and look for early signs of relapse. And I want to point out that especially for a cancer like breast cancer, you'll see that the biggest benefit, so the likelihood of actually finding a circulating tumor cell is going to be in later stage cancers. So I want to point that out because there is talk about leveraging liquid biopsy for cancer screening or at stage 1 cancers. And those platforms are validated a little bit differently usually. So if we think about, again, circulating tumor cells, it can be used at any stage, but just again, know that the most likely a patient is to get an informative result is going to be in later advanced stages. So what does some of the data look like? I'll start with the prognostic information that can be derived. So this is looking at the prognostication information that was submitted for FDA clearance and looking at the CTC counts and how they translate to a more favorable or unfavorable prognosis. And so if we focus specifically on this column, which again is the metastatic breast cancer column, you'll see that those individuals at baseline that had 4 CTCs or less were found to have a more favorable prognosis in terms of overall survival and progression-free survival, whereas the presence of 5 or more CTCs was found to have typically a shorter overall survival and PFS. I do also want to point out that sometimes, as I alluded to in this slide, there will not be CTCs present in the patient's bloodstream. Sometimes that can be because it's a very early stage where, again, we wouldn't expect many to be present, but sometimes it can actually mean that the patient has responded very beautifully to therapy. And we've seen a clearance, at least a temporary clearance of the patient's CTCs in bloodstream. So a 0 CTC result, we do consider prognostically favorable. And in other words, indicating not only favorable prognosis at baseline, but potentially indicating a favorable response to a particular treatment. On this slide, I mentioned earlier that typically CTCs do also appear in the bloodstream prior to something on imaging. And what we're really showing here is that, again, using that cutoff of 5 CTCs, if there was discrepancy between radiologic findings and CTC count, we found that the CTC test actually did more accurately predict patient prognosis than relying just on clinical radiology. And patients with the most favorable outcome had, of course, not only negative imaging, but also less than 5 CTCs, as we mentioned. So I did also mention that with circulating tumor cells, we have recently developed the ability to look at biomarkers on the cell surface of those intact cells. And so when I'm talking about biomarkers, think things like HER2, ER positive, and the way the biomarker in particular that I want to focus on is HER2, given that it does play such a critical role in breast cancer prognoses and also breast cancer treatment. Now, HER2 typically is derived through or assessed through a tissue biopsy and then applying different what's called IHC stains, as I'm sure all of you know. Information regarding HER2 can also be derived from cell-free DNA, cell-free RNA, the other type of liquid biopsy test that I mentioned. But the reason I believe that biomarker expression of HER2 with CTCs is so informative is that, again, since we have an intact cell, we're able to look on the cell surface directly for the HER2 expression. So if you think back to the pictures I showed of those different dyes, when HER2 is and I'll just go back to this image here. When HER2 is requested, we can actually apply an additional HER2 antibody stain, and based on the brightness of that stain can actually determine if a patient has if that patient's circulating tumor cell has an IHC equivalent score of +1, +2, or +3, which, as you all know, in the HER2 setting has pretty profound ramifications for treatment and prognostics as well, treatment eligibility for anti-HER2 and prognostics. When we think about HER2 as well, we do know that as patients do proceed with different treatments, that the tumor can evolve. And so a patient that was initially HER2 negative later on after treatments could become positive. Vice versa is also true. And so what we have found is that in some cases, not all, patients are being treated based on a HER2 status that is much older and might not reflect the changing tumor dynamics or changing HER2 status. So we understand that tumor biopsies can be invasive, can be difficult to achieve, especially if a patient is having response to therapy. So by offering the ability to perform essentially a liquid IHC through peripheral blood, we hope that this provides a more global landscape of the HER2 status within that patient's entire body, and also can look for conversions such as this.
How is Menarini working with clinicians, patients, and advocates to ensure this testing is accessible and inclusive?
Great question. So I will mention, or I'll reiterate, that Menarini did not acquire the cell search technology until 2016. So many of those clinical trials occurred, before Menarini had control. But moving forward, one of the things that we are doing with clinical trial enrollment specifically is, historically, many of these clinical trials have launched at large academic centers where there can be, access issues just innately. So we've really tried to incorporate community centers, community treatment centers, which will hopefully broaden access in rural populations or underserved populations. And then as we also look to the future, one of the things that I've learned at prior roles is the importance of working with advocacy groups like this one for recruitment, as well as local community leaders. It is one thing to have a lofty, important goal of having a clinical trial that is reflective of US demographics. But very understandably, there can be issues of trust with the medical community in some of those historically underserved populations. So, again, by working with advocacy groups that already have that rapport, or community leaders that already have that rapport, that is another way where we're hoping to increase participation.
Wonderful. I was actually a part of a campaign, I believe, that Menarini did. This was a couple years ago. And I was able to just share a lot of information via social media. And I got a lot of feedback. A lot of people hadn't, heard about it. And it's just opportunities like that where people, they can connect a little more with advocates and other patients. So just kind of leveraging that to kind of get the word out there is very important. What excites you most about the future of CTC testing and precision medicine?
So I think that what excites me the most is the idea of further advancements with precision medicine. So with liquid biopsy and CTCs, we have the ability to again look specifically at what is driving a patient's cancer. We used to think of it as everybody had breast cancer, and then we subdivided the triple negative and HER2 positive, and now we're even looking at individual genes, which informs treatment paths, even the step at which those treatments are administered. So I do think a lot, because of where circulating tumor cells are currently ordered in more advanced cases. I think a lot about the opportunity to give people more time and quality time with their loved ones. And obviously, there are other ways to leverage liquid biopsy in again early stage cancers, and hopefully that also means that using other platforms or other liquid biopsy tests, that we can improve outcomes, increase overall survival, and rates of remission for those early stage cases. I also think that personalized medicine has the opportunity, emphasis on quality of life, to potentially um, identify treatments that will have the fewest amount of side effects, or combinations of treatments that have the fewest side effects. So again, that the time that patient has is quality time with loved ones, friends, family. The efforts at clinical trial initiation for increasing outreach to underrepresented minority populations. So in thinking about how CTCs and even other liquid biopsy panels are being used in clinical trials, ultimately what I'll say what many physicians are looking for is something called phase 3 data or phase 3 trials. And what that means is physicians want to see that switching a patient's treatment, modifying a patient's treatment due to information they got from the CTC test, as an example, improves their outcomes. So either they're in remission longer, we look at metrics like overall survival, that more patients that adjusted therapy based on CTC results were still alive at the 1 year, 2 year, 5 year mark. So we do have that some of that data emerging now, again showing that with leveraging CTCs and intervening with HER2 does improve outcomes. Which again, that really helps with some of the downstream accessibility issues, such as once we have phase 3 data, a lot of times big national guidelines, like many of you have probably heard of National Comprehensive Cancer Network or NCCN. They'll look for that kind of data. And once it's in the guidelines, there's just vast recognition across the country and even world on how that can be implemented. So that's really, I think, high level the big way that we see CTCs being leveraged today.